Hello everyone, my name is Naamala. I'm a PhD student from Makerere University, Karolinska Institute, Stockholm, and also a nurse working with the Uganda Cancer Institute. I'm here to present one published paper about psychometric properties of the EORTC questionnaire in Uganda. The EORTC questionnaire is a quality of life instrument developed by the European Organization for Research and Treatment of Cancer and has 30 core questions or items. It assesses self-reported quality of life among adult cancer patients, and it has been used in major languages spoken in the Western world and Asia. In Sub-Saharan Africa, the questionnaire is available in 9 languages, and these are Afrikaans, Amharic, Lokano, Kiswahili, Sepedi, Xhosa, Yoruba, and Zulu. However, in Uganda, we do not have such a valid, reliable genetic instrument that can assess health-related quality of life among cancer patients, adults. So the purpose of this study was to evaluate the psychometric properties of the Luganda and English versions of the questionnaire. And please note that the questionnaire was translated in Luganda by the EORT translation group in 2015. Method. It was a cross-sectional study design that was conducted at Uganda Cancer Institute during the month of June to July 2019 by 7 trained nurses. Quality of life was measured by this very questionnaire, while clinical and socio-demographic characteristics were measured or assessed using medical records and study-specific key items, respectively. Karnofsky Performance Scale was used as a gold standard and abbreviated as KPS. Eligibility. 385 adult patients with various cancers, and these were 18 years and above, who were treated and cared for at Uganda Cancer Institute, Luganda or English speakers, with the physical and mental ability, and these were judged by the in-charges of the units. These were identified for the study. The method. The method continues. Data analysis was done using Starter version 14, and this was used by language versions, the Luganda and English. This was done through data quality, where I looked at the item means and standard deviations, flow and ceiling effects, as well as missing item responses. While reliability, we used the Krohn-Schwarz alpha, which was used to assess the internal consistency of the questionnaire, and whereby we had the alpha greater or equal to 0.7 as an acceptable value. For validity, we looked at 3 types of validity: the constructive validity, known groups validity, and the criterion validity. So for constructive validity, confirmatory factor analysis was performed to determine the adequacy of the original questionnaire, and standardized coefficients of 0.4 and greater were considered acceptable. Model fit was estimated by root mean square error of approximation, also abbreviated as RMSE, and the standardized root mean residue, the SRMR, was also used as a comparative fit index, the CFI. So acceptable thresholds for these, the RMSE, and then ranged between 0.05 to 0.08, while for SRMR was below 0.08, and for CFI, it was below 0.09. For known groups validity, it was evaluated by examining the instrument's capacity to discriminate between patients differing in disease stage, those in early stage and those in the late stage. So the criterion validity, we use the Pearson's correlation coefficient, and in this case we used the two scales of the questionnaire, that is the quality of life scale and also the physical scale. And this was compared with the Canopy performance scale, the KPS, to see how they perform. Result shows that there were flow and ceiling effects that were observed for several scales in the Luganda and English versions. However, all scales except cognitive function had acceptable Cronschwarz alpha that ranged between 0.79 to 0.96. For cognitive function, Luganda was low and had alpha of 0.66, and English version had alpha equaling to 0.50. The confirmatory factor analysis yielded good fit indices for both versions, and these were the RMSEA that was equal to 0.08, the SRMR was 0.05, while CFI was 0.93. Non-group's validity was demonstrated with statistically significantly better quality of life that was reported by patients who were in the early stage as compared to those in the late stage, while criterion validity was supported by the positive correlations between the KPS and the two subscales, the physical and the global quality of life, whereby in Luganda physical function, Luganda scored 0.75, English was 0.76, while for global quality of life, Luganda was 0.59 and English was 0.72. In conclusion, the Luganda and English versions of the EORTC questionnaire appear to be valid and reliable measures and can be recommended for use in clinical research and to assess health-related quality of life among adult Ugandans with cancer. So those are our references, and thank you for listening.